Physical Medicine and Rehabilitation at esteemed Swami Vivekanand National Institute of Rehabilitation, Training and Research. We invite him to preside as chairperson. We welcome him to lend his wisdom to today's scientific discourse. I kindly request the chairperson to take the chair. Thank you, sir. It is with great honor and sincere admiration that we welcome Professor Dr. Umasankar Mohanty, sir, an erudite scholar, luminary in manual therapy, and current president of Manual Therapy Foundation of India. His authoritative textbooks, including Clinical Symposia in Manual Therapy and Manual Therapy of Pelvic Complex, continues to serve as touchstone of contemporary manual therapy practice. His distinguished journey blends pedagogy, scholarship, authorship, and clinical wisdom. Today, he guides us into the nuanced realm of sacroiliac joint, addressing the intricacies of sacroiliac joint pathology. On the behalf of organizing committee, I warmly welcome Umasankar sir on stage and grace us with his discourse.
Jai Jagannath. Very good morning to all the delegates, respected Chairperson Dr. Behra sir. I thank the organizing committee to have given me this wonderful opportunity to present on this topic of sacroiliac joint. And I think we have, I'm planning that if we can convert it to a little bit of workshop kind of thing so that you can, we'll give the opportunity, I'll be demonstrating the techniques. Chairperson sir, with your permission, I'll be demonstrating the techniques, and then better we give the opportunity for the people, those who are interested, they can come and practice here also. So that will be, I mean, rather than just seeing one didactic interaction plus practice will be more better. With your permission, if I can. Yes, thank you, sir. Okay, so I'll be using because it is mostly a practical session, so I'll be using the college scholar mic rather than being in the podium, so that there is more dynamicity and I'll have more freedom to express myself. And before I just go ahead, I can just show you the first book I authored. That was it was on the pelvic complex, and I'll be taking the contents from this particular book, which was published in 2010.
Hello.
And
Hello.
this is the most recent one, the Clinical Symposia in Manual Therapy, which includes 16 important conditions treated with manipulative therapy. So those of you will be interested, I'll be putting the book, you can just have a look afterwards. Okay. Can I have the models? Hers. You understand which language?
Hindi and English.
Okay, fine, perfect. Hers and Jyotirmay. Okay. So, helping me, Mr. Hers and Jyotirmay, they are the models. Give a big clap for them. Okay, I think you can just sit down here. When I require, I'll just take you. Right. And the video person, I just request if when I'm demonstrating here, if I can project to the screen, so that more visibility is there to the demonstrations. Just a second. see, am I audible? Can you hear me? Last this side? Okay, right. See, when we talk about the sacroiliac joint, when we talk about the sacroiliac joint is an atypical synovial joint. It is, what is the difference between typical and atypical synovial joint? A typical synovial joint is covered with hyaline cartilage. In typical synovial joints, the articulating surfaces are covered with hyaline cartilage. Whereas in sacroiliac joint, the sacrum is covered with hyaline cartilage and the ilium is covered with fibrocartilage. Okay? So what are the different types of cartilages? Just to make it more interactive, what are the different types of cartilages? Hyaline, elastic and fibrocartilage, right? So presence of fibrocartilage itself signifies where there is a requirement. Let us understand why the nature has provided instead of a hyaline cartilage, why there is a fibrocartilage. Because the fibrocartilage can take more stress and strain. This is the joint which takes, entire upper body weight. Entire upper body weight is, a lot of weight is coming to the sacroiliac joint, and it's a very sensitive joint. Out of total 29 mechanoceptors, 29 mechanoceptors in the sacroiliac joint, 28 are nociceptors. 28 are nociceptors and 1 is a proprioceptor. Very sensitive joint. Number of receptors, you see, more than 95% of receptors are nociceptors. So whenever there is little bit more stress coming, that is going to cause the problem. So in order to understand the dynamics of the sacroiliac joint, we actually need to correct the issues of the lumbar spine also and the pelvic complex issues. Any pelvic complex dysfunction is going to irritate the sacroiliac joint because it is one of the major part of the pelvic complex. So let us see the pelvic complex. You see, what are the different joints? Two sacroiliac joint, one sacrococcygeal joint and one pubic symphysis. Okay, so can you please come, stand here, one of you, Harsh, please come, yes. Stand here, right. Okay. So pelvic complex, that loose sacrum, sacrum posteriorly, hip bone, or it is called as innominate. Hip bone or innominate. What are the joints here? Two sacroiliac joint, just turn. Two sacroiliac joint, which is atypical synovial joint. Then sacrococcygeal joint, okay? What variety of joint is sacrococcygeal joint? It is syndesmosis variety, syndesmosis. What is the meaning of syndesmosis? The stability is provided by the ligaments. When the joint where the stability is by the ligaments, it is called as syndesmosis. So we have synovial joint, sacroiliac joint, atypical synovial joint, sacrococcygeal, syndesmosis, and then pubic symphysis joint. Anteriorly there is pubic symphysis, symphysis pubis. Okay. Now that is also very important joint because it's all interconnected. You have issues with the innominate, it will irritate the sacroiliac joint. You have issues with the sacrum, it is going to cause the problem of sacroiliac joint. You have issues in the pubic symphysis, it is going to cause the issue in the sacroiliac joint. So it is all interconnected. And then the lumbosacral, the lumbopelvic complex, because the lumbar spine movements also will be affecting the pelvic complex biomechanics and dynamics. So I will be discussing about the biomechanics, integral part of the biomechanics also now. Okay. So now we are discussing about the individual bones and the joints. Pubic symphysis, secondary cartilaginous joint. So you have a secondary cartilaginous joint, pubic symphysis, sacroiliac joint, atypical synovial joint, and sacrococcygeal joint. That is syndesmosis variety of joint. So these are the joints. Now next coming to the biomechanical aspect. The stability of the SI joint and the pelvic complex is maintained by two major factors. One is form closure, other is force closure. Form closure and force closure. Okay. Now what is form closure? Now you see the shape of the bone, right? You see innominate, There is a phenomenon in the pelvic complex called as open book phenomenon and closed book phenomenon. Open book and closed book. So when you move forward, backward, right? So when you move forward, when you move backward, these phenomena happen. That I'll tell you when which phenomenon is happening in the lumbopelvic region. Okay. Now coming to the stability factors. Form closure. The shape of the sacrum. You see, what is the shape of the sacrum? It is wedge shaped, triangular in shape, right? The base is larger, apex is narrow. Correct? Now instead of being one wedge shape, you just imagine if it is like one rectangle. Instead of shape being wedge shaped, say if it is rectangular, what is going to happen? You see, it is providing the stability, just getting fit. You know, when it is like this, it fits there, right? If it is like a rectangle, you jump, and then what is going to happen? The sacrum would have gone down. So that is the form closure component. So that is providing the stability. Next is another component of the form closure, the nature of the surface, the articulating surfaces. It is, as I told you, it is an atypical synovial joint. Sacrum is covered with which cartilage? Hyaline cartilage, very good. And ilium is covered with fibrocartilage, correct? Next, if you see, compare the joint surfaces of say glenohumeral joint or the knee joint, right? You see, it is very smooth. The coefficient of friction is very low, right? So it is easy to move this joint. Whereas the sacroiliac joint is not very easy to move. It is a more stable joint. Movement is there, but it is relatively more stable. इतना लाइट मारेंगे, इतना लाइट मत मारिए, मैं उनको देख नहीं सकता हूँ. पीछे जाएंगे? हाँ ठीक है, ठीक, ओके. पीछे जाने से मेरे आंख में लगता है. मुझे थोड़ा उनको देखना है. I want to see the participants. हाँ ठीक है, ठीक है. उतना ठीक है. इतना ठीक है. ओके, थैंक यू. सेट कर दियो. हाँ. Okay. Okay, where were we? We are talking about the form closure, right? One is the shape of the bone. Next is the surface, articulating surfaces. It is rough. Articulating surfaces, it is rough, right? So that provides the stability. Because coefficient of friction you would have read in class 10th and 11th, right? Nu. So nu is quite high for this sacroiliac joint. I mean articulating surfaces. So that is the form closure. Two major factors. One is sacrum being wedge shaped. Okay, by the way, let me tell you, maybe 1 or 2 minutes to tell you why it is called as sacrum. It is coming from Latin word sacri, means sacred. You know why it is called as a sacred bone? Because you see, previous times, human beings used to be sacrificed in all civilizations across the world. You know, suppose they used to think that, maybe nowadays also sometimes you read somebody, oh, kisko bali de diya, bali pratha. Huh? So it was a phenomenon across the world. It is not a phenomenon restricted to our place or something. But I have gone across the world and I have seen that mostly the human nature remains the same. Okay, right. So then this bone used to escape all kind of sacrifices. So that is why after the death of a person, when there is a cremation and they take asti, most of the time this is the bone which remains. So this is one of the strongest bone. So that's why it's called as a sacred bone. So it has got a religious connection, being named sacri in the Greek, and otherwise in English language we call it as sacrum, right? Now coming to the biomechanical part, one is form closure. Next is force closure. Okay. Now what is force closure? Now let us see for one general understanding in manual therapy. Okay. We are in a manual therapy conference. Let us see, I am going to approach a case with a manual therapy perspective. Any region, let it be not only restricted to pelvic complex, let it be shoulder complex in general principle. See, there are 3 components which provides dynamicity, functionality for any human being or for any region. Now I am able to move, he is able to stand, you are able to sit, somebody moving the mobile phone, somebody recording there. So honorable chairpersons are sitting there. Now what happens is that First component for all of us is the passive component. Okay. Now, right now what we are discussing in biomechanics is a passive component. What is a passive component? The bone and the ligamentous component. The bony and ligamentous component. Now, let me just simplify. Suppose your femur is not working properly, or there is broken, or it is not there. Can you walk? Can you walk here? Not possible. Right? Your sacrum is broken, or any region, any passive component is broken. You cannot move. Right? Somebody whose humerus is broken cannot move it. So that is the passive component. Right? What gives dynamicity to this passive component is the active component. Now only a pelvis, only a lumbar spine, perfect bone, it is not going to move. It is not going to give the dynamicity. So what gives the dynamicity is the active component. So I am able to move my hand, move my shoulder, express myself. Now how it is happening? It is due to the active component. So active component is the muscular component, muscle and the fascia, right? Then what controls the fine movements is the neural component. That is why it's a very general principle when you approach any case, let it be a back pain case, let it be one shoulder complex problem, let it be one elbow problem, right? Now, passive component is the fundamental component. So we have to correct all the three components. All are interrelated. You know, we talk about the stability program, low back pain, lot of researchers are there about core stability programs. Yesterday we are having one session on by Dr. Sujit, my friend, about the Pilates, which otherwise we are calling as Pilates, but it's called as Pilates in Germany. Okay, so now we'll be demonstrating some of those core issues also, because next I'm coming to these biomechanical aspects. One is we're discussing already. Now I explained about the passive component, the nature of the joints. Next is the active component. Okay. Now how and what imbalances can be happening due to the imbalance of these active components. So what are the active components? That is called as a force closure component. Form closure is the passive integrity. Force closure is the muscular and the ligamentous factors in the lumbopelvic region. Okay. So what are they? Now rectus abdominis, transversus abdominis. In core muscles, core programs, we give lot of importance to the transversus abdominis muscle. Why? Let me explain why. See, in lumbopelvic stability, there are two biomechanical models. One is Barthelink model. Barthelink model, and another is Grakovetsky's model. Two models are there. Okay. Now that provides the stability. When you talk about the core stability programs, that root comes from these two. One is Barthelink model. You can write down and you can read after that, because it will not be possible to explain all the aspects of the biomechanical things. But in short, I will tell you about the Grakovetsky's model. But more appropriate model is the Grakovetsky's model. In the Grakovetsky's model, what happens is the transversus abdominis muscle. Okay. Now let us understand why core stability of the pelvic complex is important, and why it is important to correct the passive component, active component and neural component. You correct these three components, structure is fine, functionally fit. Whether it is an orthopedic surgeon or it is a physiotherapist or whoever is working, or if somebody comes with a fracture, orthopedic surgeon fixes it. There is a passive component. After that, active component has to become correct. That is not adequate, neural component has to be correct. That is how the structural management is planned. Okay. Now, what is the Grakovetsky's model? The transversus abdominis muscle is getting attached to the dorsolumbar fascia. You see the dorsolumbar fascia is here, right? Dense, white, fibrous connective tissue. Fascia, dorsolumbar fascia. Very strong fascia in the back. See, the transversus muscle goes and it spreads like this and gets attached to the dorsolumbar fascia here. It's spreading. So now what will happen? Just understand. A contraction, say you understand this is the transversus abdominis muscle, right? And it is the dorsolumbar fascia. It is coming the anterior part, right? Now when it pulls, now it goes like this, right? So when it goes like this, it will pull the spinous processes, providing the stability, correct? That spinal instability or pelvic complex instability will be moving towards stability when you do the core stability programs. And how it works, it is explained with the Grakovetsky's model. Okay. Now it goes like this. So when the muscle contracts, it will pull and it will approximate the spinous processes. So there is a nice you know, trigonometrical analysis, okay? And that angulation is nearly 30 degrees. So considering a normal dorsolumbar insertional angulation, that value comes to 0.577 is the approximation force. Now suppose the transversus abdominis TA, suppose you can write this TA, but the calculation also sometimes I teach in the class, where it goes and then sin theta by cos theta, and that total valuation, if it goes to 30 degrees, that comes to 0.577 is the approximation force. Suppose the spinous approximation force, you can write it as SA spinous approximation force is equal to 0.577 of the force of transversus abdominis, TAF you can write, okay. So more you want to read, you can just read it, the Grakovetsky's article is there on that, okay. So that is why it is core stabilizing is extremely important. Now along with this, when we activate the core, we have to work on the transversus, not only transversus abdominis, but also the multifidus muscle, okay. Multifidus muscle is the dynamic stabilizer of the spine, dynamic stabilizer that controls the fine movement, because it is more centrally located, and more peripherally what muscles are located? Quadratus lumborum is there, erector spinae is there, right? Out of erector spinae muscle, these are the important muscles. Again, I am talking about the force closure components. Little bit more explanation I am giving you biomechanically because we are in a evidence-based practice model. So I am talking about with pure research and evidence findings. Okay, let it be to the number of researchers, let it to the biomechanical researches or the different biomechanical models. Okay, so force closure component, what are the other important muscles as I told you? Rectus abdominis, transversus abdominis, okay. Iliopsoas, all muscles, iliopsoas, IT band, piriformis, or we call it sometimes as piriformis, okay. Most important one is transversus abdominis and multifidus. I was talking about multifidus. Multifidus is a deep muscle and more centrally located. That is the morphology, arrangement of this muscle. More medial, more central, and more deep. So it's a dynamic stabilizer. Okay. So multifidus activation is extremely important whenever we are dealing with any SI joint or any pelvic complex issues. Transversus abdominis, multifidus. Okay. I will be showing you some of the core stability programs towards the end. I will be going in this sequence. I will be correcting the sequence for the passive component dysfunctions first. Next, we will be correcting the active component dysfunction that includes the muscle and the fascia. Next, we will be progressing for the neural component integration. So that is how will be our plan of management for the pelvic complex or SI joint dysfunctions. Okay. I will be just taking one small break to rehydrate myself, just half a minute. You can sit down. You can sit down for some time, and you go there, you come here. You can be here. Next, you will be the model, whenever I need. Okay. Next, we discussed about the various types of joints, the various types of what is the force closure component and form closure component. Okay. Next is the common pattern of imbalances. What we come across, common pattern of imbalance, okay, in the lumbopelvic region. We have, in upper quadrant, we have the upper cross syndrome. Here we have the lower cross syndrome, okay. So what is lower cross syndrome? I will show you now on myself first. You see, lower cross syndrome typical presentation will be like this. Excessive, innominate, anterior rotation dysfunction, okay. So increased lordosis is there,
ASIs is down and PSIs is up, accentuation of the lumbar lordosis. The sacrum has gone for nutation. The sacrum has gone for excessive nutation, not mutation, nutation, N-U-T-A-T-I-O-N. You see the articulating surface of sacrum is reverse L shaped. Articulating surface of sacrum is reverse L. Now I have reversed it. It is looking like a L, right? Okay, a reverse L shaped. Where upper short arm and lower long arm. Upper short arm and lower long arm. This point corresponds to the axis of sacrum. So sacral axis is where at S2. Okay. Now if you hold in the junction point, this is a nutation moment and this is a counter nutation moment. This is nutation and this is counter nutation. Nutation word comes from Latin word nutare. Nutare means nodding. Okay. Now we are nodding the head, right? The sacral nodding. Forward nodding is called as nutation, backward nodding is called as counter nutation. So in nutation, the base comes anterior-inferior, the apex goes posterior-superior. Okay? In nutation, base goes anterior-inferior, apex goes posterior-superior. In counter nutation, the base goes posterior-superior, apex goes antero-inferior. Okay? Right? So when it will go forward, it will lead to one open book phenomenon. Okay. Now when you are bending forward, there is nutation. The more broader part is going forward. Okay. So it will be going for it to go like this. Now I am showing little more. This much movement does not happen, but to make you understand, this is open book phenomenon. Okay. Where the PSIS is coming close to the midline and ASIS is going away from the umbilicus. That will be very small movement, okay, just to make you understand. Okay, so it goes like this. When you bend forward, it goes like this. Lumbopelvic rhythm, correct? So lumbopelvic rhythm, next I'll talk about that, because then we are coming to dynamicity. I discussed the passive component, I discussed the active component, form closure, force closure, the different joints, different movements, why the nomenclatures, right? This is called as innominate or it is called as hip bone, okay. Although technically if we see etymologically, I mean already it is called as hip bone, the innominate means nominate, nominate comes from name, okay, nominate, nomination, nominate. So etymologically I am telling you. So technically innominate means there is no name, but it is otherwise called as a hip bone. But we will be technically using the term innominate. Sacrum, innominate. And any dysfunction of innominate and any dysfunction of sacrum will be disturbing the sacroiliac joint. Hence we are discussing all these things, right? So coming to the lower cross syndrome, okay. Now in lower cross syndrome, what happens? What is the passive component issues? ASIS is down, PSIS is up, lumbar lordosis is increased. Now next thing is, what will happen if lumbar lordosis increases? Because this is a pattern what we come across in our clinical practice. Lumbar lordosis increases. What is going to happen? What it will do? It will increase the facets will be getting overloaded. Okay? So that will lead in track of facet syndrome, spondylolysis and spondylolisthesis. They are in a if anterior rotation of the pelvis will lead to increased lordosis. If it is not intervened in time, these are the sequelae. This is how it will progress. Facet syndrome, SI joint pain, okay, not intervened, will lead to spondylolysis. More load will come at pars interarticularis region. The pars interarticularis region will get osteolyzed fast because of more stress. And you know, in biomechanics there is one phenomenon called as creep tendency. That will come into picture. Tendency of creep. What is tendency of creep? Creep is a principle when there is a mechanical stress, okay? When there is a mechanical stress. Now for example, we are putting say 50 newtons of force to one object here. So initial say 5 seconds there is deformation of say 1 millimeter, for example. with the time, the deformation will increase. So if initial 5 seconds or initial 1 minute, for example, if the deformation is 1 millimeter, maybe after 1 hour, the deformation will be increasing to 2 to 3 millimeters. So there will be a structural failure. So when this kind of failure will happen, it will lead to spondylolysis and subsequently it will lead to spondylolisthesis. This we need to explain to the patient. Okay. Now coming to the lower cross syndrome, we have the tightness of erector spinae. This cross of muscles, erector spinae and iliopsoas, this cross of structures becomes tight. This cross, you see, from anterior superior to posterior inferior. Posterior superior to anterior inferior, the structures become tight. Anterior superior to posterior inferior, these structures become weak. What will become weak? Abdominals and gluteals. You just observe somebody whose abdominal is very weak, very protruded abdomen, the gluteus maximus also will be very weak. Right? You sometimes, some patients, you just touch the gluteus maximus, it just sinks. I have to tell them, see, it is like a cotton. Right? You just put it and it sinks. So gluteus maximus is weak. More load will come on the piriformis, leading to piriformis syndrome. So that poor muscle will become tight and weak, compressing the sciatic nerve and leading to sciatica. That is the piriformis syndrome. Okay. So these are all connected issues. Okay, now this concept of lower cross syndrome was introduced by one very famous Czechoslovakian neurologist. His name is Vladimir. We write a JNDA like Pilates. People are saying Pilates, P-I-L-A-T, Pilates. It is not Pilates, Pilates, right? Similarly, JNDA, Janda. It is not Janda. It is pronounced as Yanda. Vladimir Yanda. Technically, we are using some term restaurant. That is a word, I think Italian word might be. That is the pronunciation actually is restora. Should we go to restora? If you tell, hey, what is this restora? Huh? Restaurant. We will go to restaurant. But actual pronunciation is restora. Okay. Now anyhow, so Vladimir Yanda, written as JNDA. Okay. He is a very famous neurologist who coined this. One of the pioneers in this muscular imbalances work. Now, erector spinae, iliopsoas are tight. Abdominals, gluteals are weak. Now, one very important principle of rehabilitation Yanda told, which may be clinically you can do some research work, maybe a PhD study you can do. What is said clinically is, whenever there is muscular imbalance, at first, stretch the tight muscles and tight fascia. Then strengthen the weaker structures. So what a study you can do, I am giving one idea, maybe I got the idea but didn't get time to do this work. Maybe any of you can do it, it will be fine. It will be very good work. So what you can do is you can do an EMG analysis of when there is muscular imbalance, do the EMG analysis of transverse abdominis multifidus. One group you do without stretching the opposite tight structure. One group, other group, you stretch the tight structures and do the EMG analysis. Maybe not only EMG, you can do the ultrasonographic recruitment analysis also. To what extent recruitment is happening, okay? So that is one very good study, maybe if any of you can take up. So clinically, that is how, what he suggests is, you have got muscular imbalance. Now suppose a patient comes when there is, you find, is tight, erector spinae is tight, abdominals are weak and gluteus are weak. Just don't start a core stability program. Okay? He suggests that stretch the tight structures at first, then strengthen the weaker structures. So I will be showing you those techniques. So this is the lower cross syndrome. Okay? Fine. So next, coming to the lumbopelvic rhythm. Okay? I explained to you that lumbar region, biomechanics, form closure, force closure, how the nutations, counter nutations. Now let me connect. Now when somebody bends forward, okay, just lift it up. Is it okay? Fine, thank you. Okay. Belt, can you loose? Okay, fine, right. Now turn like this. I think this angulation visibility will be better, right? So now what I am doing is, I will sit down. I am placing my palm of the thumb. Maybe you can check to the screen. Palm of the thumb over the PSIS. See, PSIS is the proper landmark for the SI joint. Okay? Just medial to the PSIS, there is sacral sulcus. This groove, you will find a depression. Medial to the PSIS. PSIS is the dimple area. So those who don't have dimple, don't worry. Dimple is not there also, but PSIS is there. Okay? So you can palpate the iliac crest and palpate for the PSIS. Okay? The corresponding to the PSIS normally is the S2. So I am going bit up. One thumb I am placing at the PSIS. Another thumb I am putting at the sacral base. And my index finger, left side index, I am putting at the L5 spinous process. See, iliac crest will be corresponding to L4, L5 junction. Iliac crest corresponds to L4, L5 junction. My one thumb at the PSIS, other thumb at the sacral base, index at the L5 spinous process. Bend forward. Bend forward. Bend forward. Slowly. Come back. Come back. Come back. Now slowly bend forward. Slowly, slowly, slowly. Now while bending forward, in the lumbar-pelvic rhythm, first the lumbar spine moves. Okay? First lumbar spine moves. Initial phase, sacrum is relatively stable, pelvic complex is stable, but next step, after lumbar spine, the sacrum goes for nutation. Then you can find the anterior rotation of the PSIS, I mean iliac crest. PSIS moves. Now come back. Now while moving forward, let me tell you about the lumbar pelvic rhythm. While bending forward, first lumbar spine moves, then sacrum moves, then innominate moves. That is the sequence. First lumbar spine, then sacrum, then innominate. Okay? Now next is while coming back, what happens? Going like this, while coming back. While coming back, first the innominate moves. Rhythm is reverse. Okay? Because the gluteus maximus gets activated. Right? That is the rhythm. While coming back, innominate, then sacrum, then lumbar spine. Okay? Once again. Palm of the thumb, PSIS, S2, sacral base, L5, bend forward. While bending forward, lumbar spine, sacrum, innominate. Come back. While coming back, innominate, sacrum, lumbar spine. If the rhythm is altered, say somebody has come with a disc bulge, this posture itself. So rhythm will be altered. Rhythm alteration means there is some mechanical dysfunction. Even if a person may not have pain, a simple poor muscular control also will alter the rhythm. So this is the lumbar-pelvic rhythm. Okay. Next, very important test called a Gillette test. Next one very important test is Gillette test. I think sometimes when you sit down for a long after a breakfast, right? A cozy hall, good seat. So now one important thing if you wish to do, I think not applicable for the optional for people who are sitting in front. Maybe what you can do is you can just stand up now. Do a self lumbar pelvic rhythm. Check that. Okay, now what you do is place your thumb, one thumb at the PSIS. Okay, right? You need not have to struggle a lot to identify your own PSIS. Then corresponding to PSIS, you palpate the S2 with one thumb, other thumb. Okay. Now palpate above. You can palpate for the S1 and then the sacral base. Right? Okay? Clear? Now, if you can just put it, you are putting it like this. You can just slightly twist it this way. Okay? Or you can just alter your left side index finger or any index finger, you put it at the sacral base and the thumb or the index at L5 spinous process. That is up to you. You want to put like this or like this, no problem. That is unless and until you are doing your own palpation of your pelvis, there is no issue. Okay. So PSIS, sacral base, right, and then L5 spinous process. Okay, and then what you do is you bend forward, right, bend forward and feel the rhythm. Check. First you will feel the rhythm in the lumbar spine, then in the sacral base, and then your innominate is going for anterior rotation. Okay, right. Now if you are having a low back pain, the rhythm might be altered. If the rhythm is fine, there is no issues. The rhythm is altered. Now you did for forward bending, okay? Now you do for backward bending. Same palpation, 1 PSIS, sacral base, L5 spinous process, bending forward, then you are bending backward, then come back. From forward bending, come back. Now you can feel first what is moving? Innominate. First you feel the PSIS movement, okay? We are not going for other analysis of that movement. Then you feel the sacral movement, then lumbar spine movement, okay? Now rhythm is, did you find some movement happening? Great. First thing you found some movement, okay? Now did you find that it is in sequence? Everybody, how many of you found that it is in proper sequence? Lumbar spine, sacral nutation, PSIS. How many of you found? Raise your hand. Normal, okay, fine. Altered rhythm, okay, fine. Very good, that you are telling the truth. Okay, fine. Now altered rhythm and pain. Okay. If pain, maybe when I am calling, you can come here so that we can analyze and we can treat you. 1. Altered rhythm, no pain. Do core stability exercises. Okay? So that will get corrected. Fine. Please sit down. Oh, wait, one more. Okay, one more very important one, very important. In SI joint and pelvic complex assessment. Gillette test, otherwise called as ipsilateral hip flexion test, Gillette test, Stork test or kinetic test. You read Stork test, you have seen Stork? You know what is the meaning of Stork? How many of you are Oriya? Okay, non-Oriya? Fine. Oriya, bogo देखिए bogo देखिए किम चल रहे? ये bogo को हिंदी में क्या बोलते हैं? बगुला? हाँ? क्या बोलते हैं bogo? Crane. That white crane in the rice field sometimes you see. Okay. Bogo किम चले? हम तेम चले ना? देखिए ना हम तेम चले. हाँ? That is called as Stork test. Test is like that. You ask the person to flex the hip. Okay. Flex the hip. Palpating one thumb at the PSIS, other thumb at S2. Okay. PSIS, first to do, then I will tell you what is happening. Place one palp of the thumb at PSIS, other thumb at S2, sacrum, corresponding sacral level. Okay. Sometimes there is dysfunction, it may go to S1, that is different thing. Normal we are talking about. First PSIS, other thumb at corresponding sacrum. Then what you do is flex. Ask the person to flex. You flex your hip. What will happen? Normally the PSIS is going to go down. Normally the PSIS is going to descend down. Okay. That is normal. If it is not going down, it is going up, test is positive. Positive test means that side involvement is there. Especially somebody has got SI joint pain, which is in the sacral sulcus. Classically, SI joint problem you will be getting here. PSIS, this is the sacral sulcus, this one. So here receptors are more. I'll tell you about that. What is the location of the receptors? So it will cause the pain here. Normally PSIS is going down. We are doing the movement, comes down. Not going down, going up. A positive test means that side is affected. That affected means it can be any dysfunction. It can be any of the dysfunction like upslip dysfunction, downslip dysfunction, innominate anterior rotation dysfunction, innominate posterior rotation dysfunction, innominate out flare, innominate in flare. These are the 6 dysfunctions. Upslip, very common. Common dysfunctions, upslip, out flare, and anterior rotation dysfunction. I will be showing you all the dysfunction and the managements. Upslip dysfunction will irritate the SI joint. Downslip dysfunction, not very common. Anterior rotation dysfunction, ASIS is down and PSIS is up. Okay. Now, anybody test positive? PSIS coming down, normal. PSIS going up during flexion, positive test. Okay. Do you have pain? Back pain is there? No. Only right side back pain you have. Wait, another thing, it can be if you are putting a tight belt, okay, it can be a false outcome of the test, right? Please sit down. When we talk about false outcome at test, let me just tell a little bit about statistics. You know, you have got a true positive, true negative, false positive and false negative, right? So you may get maybe a true negative outcome if you are putting a tight belt and then it is going up. Okay, now what is the mechanism? Biomechanical reason of in any dysfunction, why it is going up? Because normally there is dissociation. In case of involvement, dissociation is not happening because of protection. So it will be hiking, you know, it will be moving en bloc. It will move en bloc. So it will be going up. Positive test is because lack of dissociation in the SI joint. That is the cause. One of the very, very important tests. There are a lot of tests are there. Faber test. Lot of tests are there, right? Fine. Okay, now you come sit down. So now I will show you the management for the various dysfunctions. Can I know how much time I have? Just wanted to check the time so that I can adjust my talk accordingly. Otherwise, I can go on, right? Okay. So till now, what all things we have discussed is, we discussed about the various joints, biomechanics, maybe pathomechanics, and the test. Now coming to the different dysfunctions, okay? Now, what are the dysfunctions we told? First, I will tell you about the innominate dysfunctions. Then I will discuss about the sacral dysfunction, and last I will be ending with the piriformis syndrome. So this will be the, and last piriformis, and then I will teach you the core stability programs, okay? Fine. Upslip dysfunction. How to identify it? And why it is causing the irritation to the sacroiliac joint. I told you that sacroiliac joint is having 29 mechanoceptors. Out of that, 28 are nociceptors and 1 is proprioceptor. And majority of the receptors are located in the posterior part of the SI joint. Anteriorly, barely we have any receptors. Posterior aspect of the SI joint, we have major receptors. Okay? So whenever there is irritation to the posterior part of the SI joint, that is going to cause more pain. So upslip dysfunction. Upslip dysfunction. Just see, said this is the normal position, it is going up. So what will be our finding? Clinically, iliac crest is up. Iliac crest is up, PSIS is up, ASIS is up, and Gillette test is positive. And Gillette test is positive. And all of you did the Gillette test just before some time. What is Gillette test? When you are flexing the hip, normally the PSI, you are palpating at PSIs and at S2, the PSIs is going down. Instead of going down, goes up, test is positive. So, stand up. So, turn like this. Yes. Okay. Now you palpate the iliac crest, lift it up. You palpate the iliac crest. Say compared to left side, right side is up. Palpate the PSIS compared to left, right side PSIS is up. Anteriorly ASIS is up. All three are up. Okay? Compared to the other side, and Gillette test is positive. Flex the right hip. Do like this. Flex the right hip. ना ऐसे ऐसा करना है. ठीक है? हाँ. Flex करो. Right hip. Flex. Okay. Down. Ideal way of doing the test is this. Flex. Okay. Down. Normally PSI comes down, instead of coming down, goes up, test is positive. Do for left side. Flex it. Flex, flex, flex. Fine. Okay. Down, down, down. So here also, with flexor normally goes down, goes up, test is positive. So now, somebody might get this question. Now suppose, I am doing the testing, iliac crest is up, ASIS is up and PSIS is up in the right side. So there are two possibilities. Is it a right side upslip dysfunction or it is one downslip dysfunction of left side? Correct? When we have this asymmetry, there are two things. Whether this is the problem or this is the problem. Which is the problem? Whichever side the Gillette test is positive, that is the side of involvement. And usually, downslip is not symptomatic because it is not irritating the joint. Till now, I would have seen maybe at least maybe 30,000 pelvic complex problems till now I would have treated. Nearly, not telling you exact. Till now I have not got a single downslip case. Till now. I am hoping that one day I will get one. Because even if there is a downslip, it is not symptomatic, so patient will not come. Patient will come when they are having problem, they are getting pain. So out of these dysfunctions, upslip, downslip, anterior rotation, posterior rotation, outflare, inflare, three dysfunctions are more common. Upslip, anterior rotation and outflare. Now I will show you the management for upslip dysfunction. How to manage upslip dysfunction. Okay? Now you lie down. Lie down here. Please come. Pillowness. Car. So, fast technique for upslip management, lie down supine. Can you please remove the belt? Lie down supine. Okay. Bend it. Crook line. Come to crook line position. Remember one thing, whenever we do any procedure specially